Morning.
Morning.
I'll wait another minute and get going. All right, let's get going here. Okay, so this is a 12-year-old who has a pacemaker, and this is a pacemaker threshold test that was performed in the office. And the question I have for the audience here is, how would you program? What is the threshold, and how would you program this patient's pacemaker permanently? So why don't we go to Dr. Kalis? What do you think?
All right. Good morning, Dr. Pass. Okay, so it looks like this patient. So we're doing the threshold. So we're V-pacing initially.
So let me just interject and just say that the way that this works is that the pacemaker programmer, you ask it to drop the output, just like you would at a bedside pacemaker, until it loses capture. And that presumably is the threshold. So
So it looks like they start out at 1 volt, and then they decrease to 0.75 volts. And it looks like you lose capture at that point.
Okay, I agree.
The last two I see are not captured.
Right. So typically, the best way to do this is to use the electrocardiogram, which is what we would do in the ICU. But because we have intracardiac electrograms, we can fairly accurately measure the threshold by just seeing when the intracardiac electrogram changes. And so you correctly, Maya, noticed that the electrogram is the same at 1 volt, or presumably this was higher than 1 volt. Let's say it was 1.25 volts. Typically, it goes down by either a quarter or a half a volt each step. And whoever was doing this threshold test programmed it to pace 1, 2, 3, 4, 5 beats at each output. And it's interesting, right? The first 2 beats at 0.75 volts are captured.
Yeah.
But then we lose it. So what would you say is a threshold, and how would you, if you were asked to program it permanently, how would you program it?
So the threshold, so I guess the lowest output at which you're capturing is 1 volt.
That is the threshold.
And then I would program it. So I know we like to do twice the output or a minimum of 5. So I would program it at 5 volts.
Okay. So what you're doing is you're conflating bedside pacing with permanent, which is understandable because you're not programming too many pacemakers, permanent pacemakers. So you're right that typically at the bedside, and we're actually measuring in the bedside the current that's delivered. We can't actually adjust the voltage. We adjust the current in milliamperes. But on a permanent pacemaker, because the wire is presumably very well attached to the heart, as opposed to temporary wires where they are very poorly attached to the heart, and that's intentional. Why are they intentionally not attached very well by the surgeons of the heart?
Well, I guess eventually they're going to have to remove them, and they're going to remove them bedside. So
Exactly.
they don't want to cause too much damage when they remove the pacemaker, the wires.
Well, right. You don't want to have a retained wire, et cetera, which happens with a reasonable frequency, actually, where you pull it out and a little piece of wire stays behind, which we typically will just leave alone. And obviously that's not preferable. Anyways, so we typically will program at the bedside double the milliamperes, and then we usually say we don't want it to be below a certain amount, which would usually be 5 milliamps. Some people are more aggressive and say 10, but a minimum of double for sure, and probably a minimum of 5. But when it's a permanent lead, and when the lead is chronic, what is the definition of it being chronic, Maya?
Like this is a lead that, you've placed usually in the heart, and it's going to be there, I guess, for a while. Like if
Yes, that is
like
the
lifelong
general
is,
general definition of chronic. Yes,
until it.
the chronic problem.
Yeah.
But what would be in pacing? How long would a lead have to be in for us to sort of consider it chronic? Do you think?
I don't know. I guess I'm just guessing here, like 5 years maybe?
Oh, okay. You're very conservative there. No,
Oh,
it's
okay.
actually about 3 months.
3 months. Oh, okay.
Once a lead has been in for 3 months, we typically will call it quote unquote chronic. Now, what we normally do, and some of you have heard me say this before, when a pacemaker has first been put in, a permanent one, we assume that the pacing threshold may rise in the first 3 months. So oftentimes what happens is the surgeon puts it in, or the electrophysiologist, and the threshold may be very good. And the reason it's good is because we don't usually want to leave the operating room or the cath lab without a good threshold. So we'll put it in, and if we don't like it, like in the operating room, the Medtronic rep or I will say to Peter or Raghav, that sucks. You have to move the lead. It's not a good threshold. And typically, if it's epicardial, most surgeons will give you 1 or 2 shots, and after that they say, screw it, I'm putting it in. There's no other place to put it. I don't want to, dissect too much more heart. But when we're putting in transvenous leads, for sure, we will often move it 2 or 3 times if necessary to get a good threshold. So let's say we come out of, and a good threshold, acute threshold would be less than 1 volt for a permanent pacemaker, but we'll accept less than 2 volts. So we leave the operating room, and the threshold is 0.5 volts, and we check it the following day, and it's 0.5 volts. So you could make the argument that we could just leave the pacemaker programmed at 1 volt, which would be double the threshold. But we generally assume that the threshold is going to rise in the first 3 months, or at least before it settles into its quote unquote chronic phase. And so as a result, most electrophysiologists will not leave a permanent pacemaker wire program that's brand new at less than 3.5 volts. And I actually pretty much program everybody at 5 volts, even if the threshold is 0.5. Now, that may be aggressive, but, I think it's the safest thing to do. And so typically, when a patient has a permanent pacemaker, we say to the family, you must come back at 3 months for sure, because that's a critically important visit. Because at that visit, if the threshold looks as nice as it does in this tracing, we would turn down the output to double the threshold. Okay. And that change can literally add 3 to 5 years of longevity to the battery life of a pacemaker. So it's very important that you emphasize to patients who are having permanent pacemakers placed that they do their follow-up in the office at 3 months, because at that point we will drop the output very considerably in order to get the patient a proper output on their pacemaker. So okay, so this is let's assume for the sake of this discussion that this patient's pacemaker has been in for 3 years, and you've done this threshold, Maya. So now you see that I agree the threshold is 1 volt, which is the output at which we have documented 100% capture, and right above the output where we can't get capture 100% of the time. So how would you recommend we program this device?
So I guess since now that it's been in for a while, I would set it to 2 volts.
That's right. We would program it at 2 volts. And now sometimes you have a patient who has a threshold that's even less than 1 volt, might even be 0.5 or even 0.25. It's, really outstanding lead. Turns out that programming the device much below 2 volts does not really apparently save a lot of battery. So some would say that 2 volts probably should be the lowest you ever program a permanent pacemaker. I will often program atrial leads at like 1.5 volts if the threshold is really, really good, on the theory that loss of capture in the atrium, if that were to happen, would not be as life-threatening as loss of capture in a ventricle in a pacemaker-dependent patient. So I'll sometimes do that to sort of squeeze as much juice out of the battery as possible. These kinds of things of checking the threshold are very, very important. It's interesting, but people have done studies in adults who have had pacemakers, and pacemakers, when they come out of the box, are programmed at 3.5 volts in 0.5 milliseconds. And it turns out that something like 96% of people, when they interrogate their pacemaker at death, are programmed at 3.5 volts in 0.5 milliseconds, and at a rate of 60, which is the rate out of the box as well. So a lot of people putting in pacemakers in adults are not really fine-tuning the devices for the patients. For our pediatric patients, it's very, very important. I mean, I could see how if you put a pacemaker in a 93-year-old individual and you got 8 years out of it at 3.5 volts and 0.5 milliseconds, you'd be very happy with that outcome. But, our patients need lifelong pacing. And so if we can gain an extra year, 2, 3, 4, 5 out of every pacemaker, that could have a very meaningful impact on the total number of pacemaker surgeries that the patient has in life. So checking the threshold is very important. It's also important in pediatrics because patients grow and also are much more active than adults. And so the likelihood of a lead fracture or injury, as well as a lead movement with growth, is substantial. And so our patients' thresholds are likely changing more than they would in the adult world. So for all these reasons, we always want to check the threshold, which is a good way of assessing the integrity of the lead and the lead-heart interface. And this is one of the few tests that are not able to be done when patients are having their home checks. It does not really do a sophisticated threshold test. It will do a so-called magnet test, and we've talked about this before, that when you put a magnet on most pacemakers, it paces at a certain rate, but it also, on the third paced beat for 1 beat, will typically drop the output in half as sort of a poor man's threshold for 1 beat. So you at least know you're double the threshold, but it's not as obviously as sophisticated or as good a test as this one that we're looking at here. So yes, so we would program this at 2 volts on the assumption that this threshold is 1 volt. And if we are unsure, or we really want to be certain that we know the threshold well, you can also program the device temporarily to pace continuously at this output of 1 volt to be sure that you know that the threshold is correct. Okay. Any questions about that? All right. So this is a tracing from a Zio patch from 4:24 a.m. And I'm going to ask Dr. Mukhopadhyay, what do you think is going on here? What would you do about it?
Good morning, Dr. Pass. I'm looking at the tracing. There's a P wave in front of every QRS complex. And
is there a QRS after every P wave?
No.
So you need to say both, right?
So in the second tracing, there are like two P waves, the two P waves which are followed by QRSs, and then there's the other one where there is no QRS complex.
Mm-hmm.
And then there are subsequent P waves with QRS complexes after them. And
we sort of see here, there's a P wave without a QRS, right?
right.
And way down here. So it seems like on every strip, with the exception of the first one, there's at least one non-conducted P wave. So is this first degree heart block?
No.
Okay. Is it third degree heart block?
No.
So
This is
it's second
heart block.
degree. So
Yes.
then the question is, what type of second degree? And we remember that there is Mobitz I, Mobitz II, and then some people would say 2-to-1 heart block is a form of second degree block, but really 2-to-1 is probably Mobitz I or Mobitz II, but it's harder to tell on surface electrocardiogram. So which of those types of second degree block do you believe this to be?
I think this is Mobitz type 2 heart block.
No. It's actually probably, well, okay, the first thing to say is you really don't know for sure. No one can tell from a surface definitively, and this is where doing this on the computer and doing it remotely is a disadvantage because we can't use calipers, but there is probably a subtle increase in this PR interval with a drop P wave. If you look, but we don't really know for sure. I think on this one, I might be able to convince you that this PR interval is slightly shorter than this PR interval, right? Like this one looks like it's 240 milliseconds, and this looks like it maybe is 260 milliseconds, and then there's a drop P wave. But the general rule of thumb is, so it's hard to know for sure. So I would give you full credit for just saying second degree block here, as you did. But it's hard to tell sometimes. And every once in a while on Zeo patches, we will see a dropped P wave here and there.
In progress.
Generally speaking, I'm hearing myself. Okay. Generally speaking, we would not be terribly concerned with single dropped P waves on a Zeo patch. And so we would generally lean on saying it's probably Mobitz I, but it could be Mobitz II, but probably not. But you'd want to look for other evidence of more obvious Mobitz II at different times on the tracing. Remember, in Mobitz II, we typically see a very fixed PR interval and then just a drop P wave that doesn't appear to have, with no prolongation in the PR. And I agree that it's not the most obvious PR prolongation, but I do think if you look carefully, and if we had calipers, we would identify a subtle increase in the PR interval. So, okay, so we think probably this is Mobitz I second degree heart block. This is on the patient's Zeo. Let's just say for the sake of discussion, this patient got a Zeo for palpitations. Would you do anything about this, Kitoki?
I would probably not do anything about it.
And why is that? I'm not disagreeing, but expound on that answer, please.
I'm looking at the patient's heart rate. It's
I mean, do you ever see this in the hospital when you're doing your morning tele review?
like a Mobitz type 1 block.
Yeah.
Yes, every once in a while we see it.
Yeah. So Mobitz I, when you're sleeping, and I assume that's what's going on here at 4:24 a.m. Mobitz I is usually a benign finding in a patient, in a healthy person, usually a sign of vagal tone, etc. So generally speaking, if we saw that in the middle of the night and somebody was asleep, we would not be particularly bent out of shape about this. Obviously, the context is important. If it's somebody who had congenital heart surgery, maybe a little more concerning, but in an otherwise healthy person, we would not be terribly worried and would probably not do anything further. in an asymptomatic patient. Okay. All right. Let's move forward. This is, excuse me, a 19-year-old with a history of maternal antibody exposure. Patient is complaining of feeling tired. What is the differential diagnosis, evaluation, and treatment? So I guess the first thing to ask is what kind of pacing is going on here, and what do you think about that? Why don't we ask, let's ask Dr. Capin her view on this electrocardiogram.
Good morning, Dr. Pass.
Good morning.
So first things first, just looking globally at this EKG, it looks like there is a pacing spike prior to what looks like a QRS complex. So it looks like the patient is V pacing.
Mm-hmm.
And then moving forward, just kind of going systematically through, it looks like the patient, I'm just trying to count the small or the big squares between the QRS complexes. So roughly at a rate of 60 beats per minute.
Mm-hmm.
So moving forward, then it looks like it's pacing at a regular interval at that time.
Actually 65, but I'll give you full credit for 60.
Oh,
Okay.
thank you. So then looking forward, there does appear to be P waves intermittently through the rhythm strip.
Mm-hmm.
But they don't seem to correlate necessarily with the QRSs, and they kind of appear at random intervals. Let me see if I can just trend them, because I'm a little worried that there is maybe complete heart block with no kind of AV association.
Well, somebody who has a pacemaker, we would hope there's some problem with their
Yeah.
conduction.
Yeah, that's exactly right. So the person is complaining of being tired in the setting of some exposure. Looking at the beginning of the
Now,
strip,
remember, this is a history of maternal antibody exposure. So I'm just trying to give you an idea of why this patient has a pacemaker. Not because they're having, I mean, if my mother has some antibodies, I don't think it's having any major impact on me today.
right, I think it maybe was
Yeah.
lupus, and then the
Right,
child
exactly.
had complete heart block.
Uh-huh.
So I guess if the patient was tired or not
Me-
feeling like
Is
his
there
or
AV
her,
synchrony on this patient's tracing?
no.
So what kind of pacemaker is this? Is this a dual chamber, a single chamber? What do you think?
Most likely it would be a single chamber if there was no AV synchrony.
Right, because the P waves, as you astutely pointed out, are kind of all over the place, right?
Mhm.
If you look just at this one beat, you'd say, oh, that's A-sense V-paced rhythm, except then there's a P wave with a very long PR interval, and then there's a P wave on the T wave. It doesn't appear as if,
Mhm.
and then now here's a P wave again on the T wave. So it doesn't appear as if there's really a consistent relationship between the atrium and the ventricle in this patient.
Yeah.
So, so this is probably single chamber V pacing, right?
Mhm.
And it's probably VVI pacing. So if the patient is complaining of feeling tired, it's a chronically paced patient, what would you do for this patient?
Well, I guess I'd be a little concerned that because we aren't coordinating the A's and the V's simultaneously, they might be developing a component of heart failure in the setting of losing their atrial kick.
Okay.
So, I mean, I would not be doing this myself, but reaching out to you or another EP physician maybe to place a dual chamber pacemaker.
Well, that might be what's necessary, but would you do any kind of workup first? Like, would you just go to a dual chamber pacer right off? So I'll just say, for the sake of this discussion, this patient has been VVI paced most of their life. She's been VVI paced most of her life. So what would you, so would you just go straight to dual chamber pacing?
No, you could interrogate the pacemaker itself, assess its longevity.
Okay, so the device looks great. Its threshold is very low. The battery has 5 more years of longevity.
And then maybe just see if there's anything abnormal with the patient's serologies, like for example, are they infected with anything? Is there
Okay.
anything else that may have contributed to this overall?
Has no symptoms of any sort. So you're in the cardiology clinic. Are there any cardiology tests you could do to make you feel more better or worse about the patient?
Suppose you could do a ZO or a Holter to assess what's going on over a
Okay,
couple day
so
period.
all right, so you do a ZO and you show that he has rate responsive is turned on, so his heart rate is going between 60 and 110.
And
Any
then-
other testing you could do? Any concerns in any patient who's paced?
Well, you would also obtain your EKG or echo to
Right,
look for
so-
function.
Right, so you would want to check the echo because a small but consistent percentage of patients who are V-paced will develop a pacing-induced cardiomyopathy. So you'd want to make sure that the function is normal in somebody who is complaining of feeling tired who's paced. And in general, we like to do an echo every couple of years at least on somebody who has a permanent pacemaker with V-pacing to confirm that the function is normal. So the patient's function is normal. Is there anything else you might do? So the function is normal. The ZO patch shows proper functioning of the pacemaker without capture loss and with, not normal heart rate variability, but normal for a patient who is VVIR paced, say 65 to 90 or 95. So anything else you might want to do to figure out a reason for feeling tired?
I mean, globally, just certain labs, for example, like looking at thyroid function, perhaps.
Yeah.
Also reassessing their own medications that they may be on. I'm not sure if the patient's on any kind of antiarrhythmics that may affect other organs. So just interval monitoring as well.
Yeah, you could do all of that. That's true. But I guess what I'm trying to hint at, and I'm sorry for asking one of these guess what I'm thinking questions, but you'd also want to do a stress test, right? Because lots of people complain of feeling tired, but when you actually objectively study them, they do fine. So somebody like this, I would really want to, if the echo is normal and everything else about the pacemaker is proper, I would probably want to do a stress test in order to quantitate how well the patient can exercise. Because putting in a new pacing lead is not an insignificant intervention. And, as we've discussed many times now, we don't really want to be opening that pacemaker pocket any more times than we absolutely have to. And every time we open it, there's an opportunity to not only injure the lead that's already there, but infect the entire system. And so we really don't want to be opening the pacemaker pocket unless we absolutely need to. And so I would need more proof, assuming that the standard blood work is negative, that his echocardiogram shows normal function. I would want to know that this patient cannot exercise at an adequate level before going to the step of giving him AV synchrony. Remember, we've discussed this in the past, that AV synchrony is helpful, but is more helpful the older you are. In other words, young people actually usually have very good heart function and can tolerate AV to synchrony quite well. And when you have really good heart function, the contribution of AV synchrony can be very minimal. It might be 5 or 10% of your cardiac index. But if you have outstanding heart function, losing 5% of your cardiac index still leaves you with a very normal cardiac index. But if you are, let's say 56, like some people I know, and your diastolic function is just not going to be exactly the same as it was when you were 20 or 19. And so the contribution to cardiac index of having AV synchrony is substantially more. And in older patients, like in their 60s, 70s, 80s, it could be as much as 20 to 30% of cardiac output. So the fact that he's single chamber paced, although absolutely a possibility to contributing to low cardiac output and feeling tired, it's also very possible that it has nothing at all to do with it. The truth is, most patients tolerate single chamber pacing very, very well, young patients, which is why I often, when we have like post-op patients in the ICU go into heart block, when I'm asked the question, what kind of pacemaker do you want? I almost always say a VVI pacemaker, because I know that the contribution of atrial AV synchrony is pretty minimal in healthy young people. Now, one of the bigger exceptions are people who have a lot of AV valve regurgitation. Certainly, we can improve that with AV synchrony. So in that type of patient, I would recommend dual chamber pacing. The other reason I'm not a big fan of dual chamber pacing in small children is because of the evidence that there are long-term potential complications such as coronary artery strangulation from epicardial leads later in life. That has been described by the Boston group. So generally, less is more in all phases, all thoughts of medicine. And so in a patient like this, you'd want to do all those things, check all the lab work that Ivana just reviewed, do a full physical exam, of course, check a ZEO to make sure there's 100% capture and that the heart rates are normal. Another thing that one could do is to make the rate responsive feature more sensitive to motion so that the heart rate goes up a little bit more appropriately. Most studies have shown that the so-called rate responsiveness, which is usually from a piezoelectric crystal that senses activity, is far too insensitive, so that even though you may program the device, say 60 to 150, almost never does it go over about 90. Now, it turns out most patients don't mind that and feel fine, but that would be another potential intervention one could do, although you have to be careful with that because sometimes patients don't like the feeling of their heart beating faster when they're so used to it being a little bit on the slow side. So, okay, thank you. We'll do one more now. All righty. Wait, I'm getting a question. Can a broken lead cause this phenomenon? You're talking about this? Yes, this absolutely could be. Mahmoud's asking, is it possible that this is an example of someone who has a dual chamber pacemaker where the atrial lead has broken? Absolutely. That's a very real possibility in any patient who has just V pacing. I assume, though, that the doctor caring for the patient would know that the patient had a single or dual chamber pacemaker. But it's a good point. Every once in a while, a patient of mine will walk in the office who has a dual chamber pacemaker, and you see this, and that's a worrisome finding, obviously, because you know the patient is supposed to have AV synchrony. Okay. So this is a tracing that from a patient, and the computer analysis says wide QRS rhythm, nonspecific intraventricular block. And my question is, do you agree with this computerized analysis? And I'm going to turn to Dr. Condon and see what she thinks.
Morning. Alrighty, so if I look at the P waves in 1, 2, and AVF, they're upright. So it looks like sinus rhythm, and then intraventricular block.
What do you think about the PR interval?
Yeah, it looks short. So I don't think it's a wide QRS so much as like it might be pre-excited.
Yeah, that's exactly right. This is somebody who has WPW. So this is kind of an easy question, but it's important because you should really be very skeptical always about the interpretation on these on ECG machines. I always say the only thing you can usually reasonably count on is the heart rate up here, but pretty much all these other numbers are usually wrong or can be wrong, and certainly the analysis can be wrong. So take the analysis with a grain of salt. This comes up all the time in my clinic where the computer doesn't seem to know what WPW is. Sometimes it does, but I think it's only trained to recognize certain pre-excitation patterns, but not all of them. So this is just a patient who is in sinus rhythm and is pre-excited. And I think with that, we'll stop for today. Thank you all very much. Hope you all have a great day. Thanks for joining.
Thank you.
Bye-bye, everyone.
Thank you.